DeBakey Grand Rounds. Before I introduce the speaker, I have to give some housekeeping messages. Use the microphones to ask questions because this will be broadcasted, I think, in a YouTube channel. The recording will be available for viewing later, and you can text DeBakey to 37607 and submit questions. We have upcoming training activities, the open aortic training on October 24th, 25th, pumps and pipes in December 8th. Okay, so today we are fortunate to have Frank Bogun visiting us from Michigan. Frank has been a leader in VT for, I say, almost 3 decades now, but a long time. Frank joined the University of Michigan EP group in the 90s. This group was led by Fred Morales, who was one of the pioneers of clinical EP in the United States. And Frank was in charge of doing all the VT work from the very beginning. And that group, led by Frank, has made very important contributions as to how we treat patients with ventricular tachycardia, how we implement practical approaches to successfully treat these patients. It is an honor to have him. He's been in the United States now for almost 30 years, and you will notice he comes from Germany, but he's one of those examples of how foreigners are making America great again. Frank, take it.
Thanks, Miguel, for the kind words. I'm going to talk about imaging and how to localize and how to treat ventricular arrhythmias. I said I have no disclosures. I have a couple of disclosures. Number one, although I have an interest in imaging, I'm not a radiologist, so be kind with me about that. The second disclosure is I'm a runner. I run every day, rain or shine. Before I go to work, I go for a run. And that can be painful, especially if you're in Michigan. When you get up in the morning, it's cold outside, there's rain, maybe snow. It's painful, it can be difficult. Haruki Murakami is a Japanese novelist. He's a runner too. He wrote the book, that is what I talk about when I talk about running. In this book, he summarizes his experience with running in one sentence. He said, pain is inevitable, suffering is optional. When we do these long ablation procedures, it's painful, not just for the patient, but also for the operator. But that pain can be dealt with in a way, or at least the suffering can be minimized if we use imaging. And that's what I'm going to talk about in my presentations, how to minimize the suffering and the pain. There are other benefits of imaging, including the diagnosis of the underlying substrate. Imaging helps to plan ablation procedures, and imaging helps to improve the outcomes in different cardiomyopathy substrates. I'm going to talk a little bit about how we approach non-ischemic cardiomyopathy patients, hypertrophic cardiomyopathy and sarcoidosis, and ischemic cardiomyopathy with different imaging modalities. Imaging helps to improve procedural safety. It helps to improve outcomes in patients who have had failed ablation procedures. It helps with risk stratification, and it also helps in patients without structural heart disease. The majority of the patients, if they come to the hospital with VT or VF, they are and have a negative echo or coronary angiogram, they have no evidence of structural heart disease. If, however, we do a CMR on these patients, the number of patients with out structural heart disease decreases to the benefit of patients with non-ischemic cardiomyopathy. How do I do the pointers, or can I use the mouse to direct?
You have to scroll it
The mouse. Oh, no, that's a phone. Okay, good.
You see it, but you have to go all the way. Okay. And now, keep going to the right. Let it show up there.
Okay.
As you keep going to the
Excellent. Good. And this is what we want to know about imaging. We want to know the scar, is there scar, and the extent of the scar. Because arrhythmias come from scar tissue, and myocytes within scar tissue, they lose the side-to-side connections, and the impulse propagation in the perpendicular direction, perpendicular to the myofiber orientation, is delayed and sets up a situation that is favorable for reentry or ventricular tachycardia to occur. Talking about imaging, we have to remind ourselves that the spatial resolution is different in different imaging modalities. It is in the 1+ millimeter range in CMR, in the sub-millimeter range in the CT, and in photon count CT, it's in the micrometer range. I have no examples, but photon counting CT will be the future of CT imaging. We compare CT with CMR. With respect to spatial resolution, CT is superior to CMR. When we look for the arrhythmogenic substrate in CT, we look for ridges within wall thinning, calcifications, fat, or late iodine enhancement. In CMR, we mainly look for late gadolinium enhancement. With respect to the coronary arteries, the spatial resolution is superior in CT. Same with the anatomy of papillary muscles. However, when we look at the arrhythmogenic substrate, CMR has an advantage over CT with respect to intramural versus non-intramural substrate, papillary muscle involvement, and demonstration of superior outcomes when imaging is used is present for CMR, but not yet for CT. CT, however, helps to get epicardial access, and for procedural planning, it depends on the arrhythmogenic substrate. CMR is definitely superior to CT in non-ischemic patients, and in ischemic patients, they are about equivalent. When you looked at a patient population with ischemic and non-ischemic cardiomyopathy, in whom we performed all 3 image modalities, CMR, CT, and intracardiac echo, in CMR, here we go. With CMR, the arrhythmogenic substrate was identified in the majority of patients with ischemic or non-ischemic cardiomyopathy. In CT, however, was in ischemic cardiomyopathy, the arrhythmogenic substrate was identified in ischemic cardiomyopathy more so than in non-ischemic cardiomyopathy. In ICE was about the same. Combining all 3 imaging modalities identified 100% of the VT target sites in this patient population. When we do ablation procedure, we essentially apply Sutton's law. Sutton was an American bank robber. After he was caught, after having robbed many banks, he was asked, why do you rob all these banks? He said, well, I go where the money is. We want to do the same thing. We want to go where the money is. Here you see an epicardial scar in the CMR sequence, stacked sequence from base to apex. This is the scar extracted and after 3D modeling here, superimposed on the endocardium in green. And here you see an epicardial voltage map, bipolar voltage map. Red means low voltage, indicative of scar, and we have 3 sites here that were critical for 3 different ventricular tachycardias. When we then overlay the exported scar, this matches. This is our initial experience when we used imaging for patients with non-ischemic cardiomyopathy. If the scar was predominantly endocardially located, we could get rid of all of the arrhythmias. If the scar was epicardially located and we reached the epicardium through a subxiphoid puncture, we could get rid of all of the arrhythmias. If the scar was intramurally located, we had trouble. we couldn't eliminate these arrhythmias in these patients. We have been getting better with these scar locations, but this is still one of the big problems that we face when we deal with patients with intramural scar. Imaging helps to identify the optimal access road. In this patient is a patient with ischemic cardiomyopathy. He has transmural scarring. The optimal access road is the left ventricular endocardium. This patient has non-ischemic cardiomyopathy with epicardial scarring. The optimal access road up front would be the left ventricular epicardium. In this patient with non-ischemic cardiomyopathy and intramural septal scarring, the optimal access road is the left and the right ventricular endocardium. Needless to say, of course, if you have isolated papillary muscle scarring, the optimal access road for an ablation is the left ventricular endocardium. I'm going to want to show you how we like to ideally use imaging when we target ventricular arrhythmias. In this patient, 68-year-old patient with non-ischemic cardiomyopathy, recurrent ICD discharges. This is his VT, has a left bundle branch block, inferior axis ventricular tachycardia. This is the CMR of this patient. Short axis view, long axis view. You see thick intramural delayed enhancement in the basal septum. This is the 3D reconstruction in gray of the patient's CT and the coronary arteries together with the phrenic nerve. And also co-registered here is in yellow is the intramural scar from the CMR. What we typically do in these patients is we start with image registration. For this, we use intracardiac echo to adjust the left and the right ventricles, and then use another fiducial point. We use typically the LV apex, the RV apex, and the left main, and then we register the pre-procedural imaging. The next step that we do is we do perform programmed ventricular stimulation to identify inducible ventricular tachycardias that we want to get rid of. The next step is we perform image-guided mapping. We do a voltage mapping, electroanatomic voltage mapping, focusing on the registered area of the scar. We perform mainly pace mapping in these patients if the ventricular tachycardias are not hemodynamically tolerated. Once we have identified an area of interest, and you can see here, this is the area of interest. This is the ventricular tachycardia. We perform pacing and have an almost matching morphology in this area where the catheter is located here. The next step is we induce ventricular tachycardia and perform ablation, and ideally the ventricular tachycardia terminates. That's the ideal situation. Unfortunately, we cannot always do this, but it's at least how we like to use imaging. This case, however, will show you the benefit, the real benefit of imaging. This patient is a 72-year-old patient who had 2 failed prior ablation procedures for VT. He's asymptomatic on maxillotin, but wants to come off the medication. He's referred to us for an epicardial VT ablation procedure. This is this patient's ventricular tachycardia. Right bundle branch block, inferior axis. This does not look like an epicardial ventricular tachycardia, but we did the electrophysiology procedure in this patient. And this is the ventricular tachycardia that we induce in the EP lab. It matches with the patient's clinical VT, and we have actually, this is the first location that the ablation catheter that you see on bottom, the tracings on the bottom, is actually located. We have some early timing, minus 25 milliseconds. That's early for us. And we decided to deliver RF here. And this terminates the ventricular tachycardia. Keep in mind, this is the first location that the catheter was in. And this patient had 2 failed prior ablation procedures. So where is the catheter located? And why did this work? This is this patient's CMR study. You can see that the basal septum, there is intramural late gadolinium enhancement deep in the septum. And you can see here, this is from the ablation lesion, bright core lesion. And when we look at the long axis view, you can see that this scar that you see here in the short axis view actually extends to the right coronary cusp, the right sinus of Valsalva. And this is where the catheter was located. The right sinus of Valsalva sits on the septum, and this is where the ablation was carried out. So imaging helps. Imaging helps to predict and improve outcomes in patients with non-ischemic cardiomyopathy. We published this a few years ago, a series of 96 patients with dilated cardiomyopathy who underwent VT ablation between 2006 and 2016. Since 2012, we use CMR in all of our patients pre-procedure. We looked at the short and the long-term outcomes in these patients, had 41 patients who had a CMR prior to the procedure, and 55 patients who did not have a CMR prior to the procedure. These are the short-term outcomes with respect to inducibility. The majority of the patients in whom we had imaging were rendered non-inducible after the ablation procedure, compared to patients in whom we did not have imaging prior to the procedure. And this also translates in better long-term outcome in the patients who have had imaging compared to the patients who have not had imaging. If we know where the scar is, we focus on the scar, and we are able to eliminate most, not all, but most of these arrhythmias, but we have to know where the scar is located. I'm going to now talk a little bit about non-ischemic cardiomyopathy and how we can target the intramural substrate. This is a patient or CMR where you can see the outline of this intramural scar in the long axis and here in the short axis view. This is a 3D reconstruction of combined CTs and CMR. And this is what we see in patients with non-ischemic cardiomyopathy. They have either a peri-aortic scar, the scar here, or they have a scar that's located in the infralateral left ventricular free wall. Usually the scar is located basally. This is a table that shows some selected studies that were carried out in patients with non-ischemic cardiomyopathy. I separated them to studies from the very early 2000s to later studies. And when we look at the acute success rate, this was not too bad, but the recurrence rate is quite high in these patients. And when we average all of the studies that came out later that I put on here, the success rate didn't really get better, and the recurrence rate didn't get better either. And the problem is, in the majority of these patients, the intramural scar. I'm going to share this patient with you that changed our approach to some extent when we deal with these intramural scars. 62-year-old patient, recurrent ICD discharges for VT, ejection fraction of 20%, refractory. VTs were refractory to amiodarone, but he had only 1 or 2 episodes of VT per year. So he's doing relatively good, but he wanted to come off amiodarone. So we plan an elective ablation procedure and perform a cardiac MRI beforehand. You can see this is this patient's short axis view, basal short axis view, and see there is a lot of scarring here. You can see this is actually intramural scarring. So we do an voltage map in the endocardium, and not surprisingly, there is almost normal voltage, so there's no real scar. On the epicardium, it looks very different. We have a lot of low voltage here, and that may be a combination of scar and the epicardial fat that also results in low voltage in this area. So in this particular patient, we were able to induce 18 different ventricular tachycardias when we perform program stimulation. We performed extensive epicardial ablation, but several VTs after long procedures remained inducible. They were non-clinical, so we are hopeful they will remain non-clinical. And minimal ablation only in the LV endocardium. But the patient needed to intubate it for VT storm within 12 hours after the procedure. So this is an electrophysiologist's nightmare. We took a perfectly stable patient and made the patient unstable. And it's a problem. So what we did in this patient is we took him back to the lab a few days later. This is again the electroanatomic voltage map showing normal voltage. Most of it is purple of the left ventricular endocardium. This is this patient's scar in the same view. And what we did is we did extensive ablation on the left ventricular endocardium. Also on the, again, extensive ablation on the epicardium. And we endocardialized the intramural scar with this. We were not able to capture in this anymore. The patient was then rendered with this procedure non-inducible and had no VT recurrences subsequently. We've done this approach in other patients in whom we have intramural scar. First, we start with a localized approach on one wall, and if this is effective, we are done. If it's ineffective, then we do extensive ablation on the opposite wall, and if this is effective, we are done. If this fails, we have to scratch our heads and we have to think about alternative options. And this actually works. It works in most of the patients when we can get rid of the ventricular tachycardias with this extensive approach. But it doesn't work in all patients. In patients in whom it does not work, they have a real poor prognosis. And in the patients in whom it does not work, they have what we call a scar depth index that is more than 17% of their scar circumference is located at a depth of more than 5 millimeters when we look at imaging. This shows you one of the patients in whom we had really deep-seated intramural scar, and the procedure failed to eliminate this patient's ventricular tachycardia. This patient subsequently underwent cardiac transplantation, and we could look at the scars that we actually. The ablation lesions that we delivered in this patient. The scar is shown here in gray, and the ablation lesions reach 2 to 3 millimeters in depth. This was not sufficient to eliminate this patient's ventricular tachycardia. There are other approaches that help us to reach deeper in the intramural substrates. We can do a targeted ablation with simultaneous unipolar or bipolar ablation for tolerated or untolerated VTs. We can do alcohol ablation. And Dr. Valderrabano has been a key pioneer in this technology and has changed the field with respect to targeting very deep substrates with this technique. We can use needle ablation, where we ablate through a needle that's stuck into that's at the tip of the ablation catheter. And unfortunately, right now, none of these catheters is approved. We can do radiation therapy. We can do pulse field ablation, which has the advantage to reach deeper, especially in the presence of scarring, or we can do cryoablation with ultra-low temperatures. This is a patient who had 5 failed endocardial ablation procedures. You can see the ablation lesions here in the CMR of this patient. There's no scar, as you can know. Prior to the procedure, there was no scar. This is after a bipolar ablation procedure that reached through and through the septum and eliminated this patient's intramural arrhythmia that came from without scar tissue. This is an example where we have a catheter in one of the septal veins for the great cardiac vein. You can see a catheter in the left ventricular outflow tract, and here the right ventricular outflow tract, and we ablate simultaneous between those two catheters in order to reach deeper lesions, which is superior to sequential ablation from either of these sites. And another patient in whom we failed, in whom we did actually radiation treatment, and you can see here the radiation dose in the planning sessions. In patients with non-ischemic cardiomyopathy, the scar has often a basal distribution, and we can take advantage of that when we have imaging that shows us where the scar is located. The coronary venous system is basally also located in a basal distribution too, as are the sinuses of Valsalva. This patient here, we can see here, this is a CT and MRI 3D reconstruction. You can see the scar in blue here from the MRI. You can see the coronary venous system, and the catheter here is in a location where we have matching pacemakers for particular ventricular tachycardia. This is a marginal branch, and we could eliminate this patient's ventricular tachycardia from ablation here. If the distance to the core scar is less than 7 millimeters in patients with non-ischemic cardiomyopathy, we have a good chance to eliminate these patients' VT without the need of epicardial subxiphoid access. Same with in patients with periaortic scarring. If the periaortic scar volume is more than 1.2 cubic centimeters, this predicts also that VTs can be reached from the sinuses of Valsalva, or if there is contiguous scar in a 1 centimeter aortic valvular perimeter. This is shown here in this particular patient, the short axis view. You can see the scar here reaching the coronary, the aortic cusps, the coronary sinuses of Valsalva. This is the 1 centimeter perimeter. This is more than 1 centimeter in the short axis view. And this is a 3D reconstruction. You can see this 1 centimeter perimeter is complete. In this patient, it is not complete. This patient had no VTs that we could reach from the sinuses of Valsalva. This patient did. Hypertrophic cardiomyopathy, patient with deeply seated intramural scarring that was not approachable from the endocardium, but you can see that the scar extends to the epicardium here. The catheter is now on the epicardial surface. This is the 3D reconstruction of the scar location, and at this location we have matching pace maps for one of the VTs, and we could ablate this patient's VT from an epicardial approach. In sarcoidosis, we published our data from the Cardiac Sarcoidosis Consortium a few years ago. The patients, there were more than 150 patients who underwent VT ablation procedures in multi-center registry. The patients who had the best outcomes were the patients who had the more preserved ejection fraction and patients who had no inflammation. However, the majority of the patients whom we take to the lab, we can't wait until they have no inflammation. Unfortunately, most of the patients still have inflammation when we have to take them to the lab because arrhythmias cannot be otherwise controlled. So how is imaging beneficial in these patients? It's shown in this particular patient. We have the right ventricular, again, a voltage map showing low voltage areas in the apex and in the right ventricular outflow tract. This is the septum. And we have the catheter, the apex, and we have a matching pace map for this particular ventricular tachycardia. Now, the catheter in the same patient is now in the outflow tract, and we have a matching pace map for this PVC that actually triggered ventricular fibrillation in this patient. We can now register the PET data to the electroanatomic voltage map, and you can see the areas where we have FDG uptake matches with the areas where we have VT target sites. We demonstrated this in several of these papers are still in revision or submitted, that the majority of the ventricular arrhythmia target sites are in areas of FDG uptake in patients with sarcoidosis. We also reported on a recent sign that we call the T sign, which is a CMR phenotype with a favorable ablation prognosis in these patients. You can see there's dense delayed enhancement in the septum, transmural delayed enhancement in the septum that extends to the RV outflow tract and the left ventricular outflow tract. And this has a T shape, so we call it the T sign. This is the electroanatomic voltage map in this patient showing that there is low voltage in the corresponding areas. The 3D reconstruction of this particular patient showing this area of delayed enhancement. When we want to get rid of these arrhythmias, we have to map in the sinuses of Valsalva, in the left ventricular outflow tract, and in the right ventricular outflow tract. All of these structures are involved in this pattern of delayed enhancement, and if we do so, these patients often have no recurrences when we do VT ablation procedures compared to these patients. This is a patient with cardiac sarcoidosis with deep intramural seated scar, 3D reconstruction here. In this patient, this is not a T sign, obviously. We were unable to eliminate permanently his ventricular tachycardia. Shifting gears again to ischemic cardiomyopathy, you can see here the wall thickness, a wall thickness of less than 5 millimeters in patients with prior coronary with prior infarcts indicates scar tissue. This is the very thinnest area in dark red. This is separated through a thicker area. Here, this is superimposed on the electroanatomy voltage map in a patient with a large anterior wall infarction. These two dots indicate an area where the ventricular, or that was critical for ventricular tachycardia. And here, this is another example where you have a ridge that is thicker than the surrounding thinning of the myocardium. And this is a high-resolution voltage map that shows you that the ventricular tachycardia slowly goes through these areas and can be ablated with a single ablation lesions in this area. Myocardial calcifications indicate fixed borders. This is myocardial calcification that we can pick up in CT. We cannot pick those up in MRI. And you can see here, this is a 3D reconstruction of the calcification shells in a patient, a young patient who had a coronary artery dissection while she was pregnant in her 20s and had VT subsequently. These areas of gray we cannot capture with maximal output, and this is actually where the calcium is located when we registered it. And again, here between these areas of calcifications, we have a critical area for a particular ventricular tachycardia. Now, talking about safety, imaging helps with safety. In this particular patient, this is a 22-year-old patient with frequent PVCs located in the epicardium that we could reach with the catheter in the anterior interventricular vein. We were about to come on ablation when we registered the imaging that we had, and this looks very close, the catheter, he is very close to the LAD, so we injected the arteries because imaging may not be perfectly registered, and confirmed that this was too close to ablate in this particular patient to a critical vessel. Imaging helps us also to identify thrombi. Here you see a thrombus in the inferior, in an inferior wall distribution. The long axis view shows this is an inferior aneurysm. This thrombus was not identified by CT or contrast-enhanced echocardiography. Here it's a more frail-looking thrombus in MRI. We looked at a series of patients with CMR, CTA, and contrast-enhanced transthoracic echo. All of these patients had all three imaging modalities. Thrombi were identified in 9 patients with CMR, 7 patients with CTA, and only 2 patients with transthoracic echo. You have to keep that in mind when you do imaging before these ablation procedures. When we have thrombi, we give them patients anticoagulation and ideally repeat imaging down the road. And in about half of the patients, the thrombi disappear, but in some patients, the thrombus, like here in these patients, the thrombus is chronic, laminated, and doesn't change. And so in these patients, there is a possibility that the thrombi may actually shelter the areas of interest. And we could not capture this area in this particular patient because of the thrombus that was there chronically. We had to go to the epicardium, map the epicardium, demonstrate that this is a critical location, and eliminate the arrhythmia from the epicardium. I talked about reentry now. We talk a little bit about focal arrhythmias, PVCs. Is imaging helpful in these patients too? Yes, it is helpful. These are patients who have frequent PVCs, 191 patients in whom we performed mapping and ablation. CMR was done in all of the patients and showed scar in 29%. The scar was intramurally located in all of these patients, and the site of origin was intramural in most of these patients, not in all, but in most of these patients. So it's important to keep that in mind. This is one example of a patient like that who has intramural scar. The catheter is in the great cardiac vein, actually in the septal vein here, very close to the register scar that's shown in green. And here, this is actually the effective ablation site for this particular patient where we could ablate in the septal vein. For me, when I see patients with frequent PVCs, I have to think about PVCs maybe the marker for the presence of structural heart disease. And structural heart disease means scarring. And scarring means the patients are potentially at risk for sudden cardiac death. This is highlighted by this particular patient, 62-year-old patient with asymptomatic PVCs. He had an aortic valve replacement for bicuspid aortic valve stenosis. PVC burden was 22% with an ejection fraction of 45%, and the CMR showed intramural septal scarring. We thought the ejection fraction was low because of the frequent PVCs. This shows the scar in the intramural septum, and we always perform program stimulation in these patients. And the patient had inducible sustained monomorphic ventricular tachycardia. He never had VT before, but he had inducible VT subsequently, and he received a defibrillator implantation on top of the ablation of his PVCs. This is not an isolated case. We've seen quite a bit of patients like this. This is a series that we published a few years ago, where we had about 280 patients. 25% had scar in CMR, the remainder did not. And out of these patients, 10% had inducible ventricular tachycardia. The other patients who had scar but no inducible VT had a smaller scar. So you could say, sure, certainly the ejection fraction in these patients was lower if they had more scar, but that was actually not the case. This translates also in improved survival if the patients have no inducible VT compared to patients who have inducible VT who all actually underwent ICD implantation. It's a recommendation based on an expert consensus document to perform program ventricular stimulation in patients who are taken to the lab for ablation of frequent PVCs. Are CMRs contraindicated, or do they have limited value because of artifacts? You see here, this is a patient who has an abandoned lead. We've done many CMRs on patients with abandoned lead and have had no major complications in these patients. Still, it is considered a contraindication. Artifacts are a different issue. We still see quite a bit of artifacts, like in this particular patient. But when we use wideband sequences, the artifact cannot always completely be eliminated, but can be minimized, like in this patient where we see actually late gadolinium enhancement in the basal septum that corresponds to the low voltage that we have. This is a patient with cardiac sarcoidosis in the right ventricular outflow tract. And it is also in the expert consensus document that it's beneficial to do a CMR before patients undergo ICD implantation procedure. Now, ablation lesions, I talked about this a little bit earlier. Ablation lesion can be imaged with CMRs too, and it can be beneficial when we plan for repeat ablation procedures. We differentiate dark core lesions. These are lesions that are on scar or adjacent to intramural scar, and bright core lesions that are lesions that are delivered, that we can see in CMR when our RF has been delivered on normal tissue. This is a cartoon that shows you this is the scar, and this is after the ablation. You can see here, this is a patient who had a VT ablation 2 years earlier. This persists. This is due to microvascular obstruction and persists for quite a time after ablation procedures. I showed you this picture earlier. These are ablation lesions. This is the area where we have this microvascular obstruction, and when we look into histology, the vessels, the small vessels are obstructed indeed, and this is coagulative necrosis. Again, this is a patient who has had an ablation procedure on top of scar, and this is a bright core lesions where an ablation was delivered in areas without scar. How can this be helpful to us when we do ablation procedures on redo patients? This is a patient who had an ablation procedure a year early and had recurrent VT. You can see here in orange the dark core scar, and this is the repeat ablation procedure in this patient. We have a lot of areas that are gray where we cannot capture, and this corresponds to the dark core that's here in dark blue, and the scar of this patient is in light blue. This patient had an extensive ablation procedure, but not everything was ablated. This area was not ablated, and this was actually critical. This area between the dark core and the mitral annulus was critical for this particular ventricular tachycardia. So when we do extensive ablation procedure, we can change the arrhythmogenic substrate and create new arrhythmias. And knowing where the ablation was performed helps to plan another ablation procedure. There is benefit of imaging also in patients without structural heart disease, especially patients with papillary muscle arrhythmias. You can see this is an ICE image of the anterolateral papillary muscle, and the catheter is right between those two heads. This is the 3D reconstruction of the ICE images, and here of the whole heart. With ICE, we can also pick up areas of increased echogenicity that you see here, and this is shown here. This is the ICE reconstruction of the posterior medial papillary muscle. And here, this is the corresponding MRI of this patient. You can guess that there is some delayed enhancement here in the field of 3D reconstruction with the catheter at this location, at a critical location for this particular PVC. Now, black blood imaging with LGE helps to better identify these papillary muscle areas of late gadolinium enhancement. We don't know, is this real or is this an artifact? But when we do black blood imaging, we can demonstrate this is actually real scar. And this helps also to look at patients' outcomes if we know that there is scar in the papillary muscles. So let me summarize the value of imaging in VT management. Before an ablation, it helps with the diagnosis of the underlying etiology. In the planning process, it helps to detect thrombi, and it helps to localize scar and plan for an optimal access route. During the procedure, there is enhanced definition of the arrhythmogenic substrate and the anatomy, and it helps to identify critical structures like coronary arteries or the phrenic nerve. Post-ablation, it helps to characterize ablation lesions and plan for repeat procedures. In conclusion, imaging with CMR-CDA-defined scar helps to identify the arrhythmogenic substrate in patients with cardiomyopathy, helps to plan an ablation procedure in patients with arrhythmias and cardiomyopathy, and CMR-defined scar integrated in electroanatomic maps improves outcomes compared to historic control groups. CMR can safely be done in patients with implanted devices without major artifacts in most patients, and it helps to localize prior ablation lesions that may have involved in a modified substrate post-ablation. And ICE is beneficial in targeting papillary muscle ventricular arrhythmias. This completes my presentation. Thank you for your attention.
So Frank, that was a great review. A few questions pop up in my mind. As you can see in the field, there's been a little bit of a dichotomy in the VT substrate assessment. On one side, we have people that emphasize the imaging and the non-invasive definition of the substrate, so you can target it even empirically. And on the other side, you have people that are advocating functional characterization of the substrate and not ablating just based on imaging or based on the scar location. What's your position in this?
Yeah, that's a great question. So it goes a little bit in the direction, can we identify the arrhythmia? Can we sufficiently identify the arrhythmogenic substrate with imaging? Are there fixed areas that are fixed as opposed to functional areas where the arrhythmia itself can generate areas of functional block? So we looked at that in patients in post-infarct patients. They are probably the easiest patients to look at. When we did high-resolution mapping in these patients and looked into the ridges from CTs and identified that the primary ridges, and I would define primary ridges as a ridge that actually is involved in ventricular tachycardia, that those primary ridges often correspond to the primary deceleration zones that we can obtain when we do functional mapping. And that is not published yet, but we have these data. And so they are complementary. So we can use this type of data to actually take a patient to the lab, have the imaging there, do some functional mapping without induction of ventricular tachycardia, and use the combination of both to identify the areas that we have, which is great. And that is probably where the future is going to go. I think they are complementary.
Also, do you think, I think that the imaging it's at a very crude infancy. Like we know from MRI, we see the delayed enhancement areas as locations of scar. You mentioned the microvascular occlusion as another type of imaging characteristic of the scar. Salman Nazarian at UPenn is talking about lipomatous metaplasia that could be identified with CT. So now it's not just scar or thinning. The thinning is the crudest thing. Do you see that refinement of imaging characterization, not simply scar yes or no, particularly combined with intraprocedural imaging, where newer intracardiac echo images can really see stuff, different echogenicity characteristics of the scar? Do you see that in the future we could have a more sophisticated characterization of substrate beyond scar versus no scar?
Yeah, I mean, the hope is going in that direction. Initially with CMR, there was the gray zone, and the gray zone was supposed to more of the arrhythmogenic substrate, but it hasn't really panned out that way. So there are different, there's of course an interest to get it down as small as possible to minimize ablation procedures, but it's an area in flux. In a way, the photon counting CT is the hope that we can narrow down the areas of interest by having higher spatial resolutions, which limits our ability with CMR to better identify areas of interest. And it's going in that direction. Whether it's going to be eventually